Okay. Okay, thank you very much, everyone. Let us start because we are already some 4-5 minutes late on starting. May I request President Nepal Orthopedic Association, Dr. Rabindralal Pradhan, to give some opening remarks, please.
Thank you very much, Dr. Amit, and welcome everyone to the third Research for Busy Clinician Part 3. I think this is an ongoing process that we've been initiating, and thank you very much, Dr. Amit, for keeping it continuation. In this webinar, we have two very prominent speakers, one from India, Dr. Ashok Shyam. Thank you very much and sparing time and giving your experience and sharing with us. And Professor Jay Shah is always there. He's part of our team now. And I'd also like to welcome Professor Gyanath Baral. We are very fortunate to have him here because he is the president of our Research Society of Nepal. So it's an honor. Thank you very much, Professor Baral, for spending time with us. And also Dr. Dipesh Tamrakar for giving us time and sharing your knowledge and on how to go about doing research with SPSS. With that, welcome once again, and hope we have a very fruitful session this time. Thank you, Amit. Over to you.
Thank you very much, sir. Deepak, my screen is visible, right?
Yes, it's visible.
Okay, thank you everyone for being with us, especially the faculties from India, Dr. Ashok Shyam, and then other faculties, Dr. Jay Shah, Dr. Tamrakar, and our own Dr. Baral for being with us. So this is a third series of research for busy clinician, which has been initiated by Nepal Orthopedic Association. We actually started 2 months ago on 5th June. At that time, it was the first series of this research for busy clinician. Then second was on July, and today we are here for its third session. And if you see all these pictures, you'll find out that we were privileged to listen to all these eminent speakers. And today we have a very special speaker. So let me start with the introduction of Dr. Ashok Shyam. We all know him from the Ortho TV. He's a founder of Ortho TV. He's founder of Orthopedic Research Group. He works as an orthopedic surgeon in Sancheti Institute of Orthopedics and Rehabilitation. It's Pune, India. He is a head of the Indian Orthopedic Research Group and co-founder of Indian Orthopedic Research Society. He has more than 100 scientific articles published in national and international journals, along with 12 book chapters. He is the editor-in-chief of Trauma International and Journal of Orthopedic Case Reports, one of the very few journals who promotes case reports, and associate editor of Asian Journal of Arthroscopy and ACTA of Shoulder and Elbow Surgery. He is actively involved in academic research and regularly conducts workshops and lectures in medical colleges and conferences. So I've been privileged to introduce him, and I know him personally as well. Maybe Dr. Ashok doesn't remember when I was in 2008 in Sancheti for a fellowship of about 6 weeks. I saw him, how energetic he was, even in 2008, how actively he was involved in research, even in 2008. And it's really nice to see that how Ortho TV has evolved and it is educating us in all aspects of orthopedics. We all know Professor Jay Shah. He was a former Vice Chancellor, President of Patan Academy of Health Sciences. He is immediate past president of Society of Surgeons of Nepal and gastrosurgeon, Nepalese Society, General Secretary of Nepalese Society of Gastroenterologists. He is visiting professor in various colleges. He is president of Nepal Association of Medical Editors. This is Nepal Association of Medical Editors is working for the improvement of editors and the peer reviewers and even the authors. He is member of various other societies, IRB, and WAME and APAME. He is chair of the ethical committee of Patan Academy of Health Sciences, and he is also chief editor of Journal of Patan Academy of Health Sciences. For most of the Nepalese orthopods, Professor Jaisa is a known personality to us. On behalf of NOA, I'd like to take privilege to introduce Professor Gehenath Baral. He's a professor of obstetric and gynecology coming from Nobel Medical College, which is in the eastern part of our country, Biratnagar. His one slide CV was very small, but if you start discussing and talking about Professor Gehenath Baral, it's very long, history of Dr. Gehenath Baral. Currently, he's chairman of Nepal Health Research Council, which is a national body and looking after all the health and research. And I would request each and every participants today to, ask more and more questions to him because he's the authority to answer most of the questions. He's also coordinator of Health Science Cluster, University Grant Commission. He's chief editor of Nepal Journal of Obstetric and Gynecology, and he's editor of various other journals. He's, very proficient researcher, huge experience in different types of researches. So we will definitely be benefited by his presence here. Dr. Dipesh Tamrakar, he comes from Kathmandu University School of Medical Sciences. He is assistant professor there in the Department of Community Medicine. He pursued Doctor of Medicine in Community Medicine and Tropical Diseases from BPKIHS, Dharan. He is trained in epidemiology and the biostatistics. That is what he's going to talk to us today about SPSS software, how to use it for research. He is leading several infectious disease surveillances and clinical trials. He has multiple publications in national and international peer-reviewed journals. And last but not the least, our own Dr. Deepak Shrestha. We all know him, consultant orthopedic surgeon and spine surgeon at Dhulikhel Hospital, Kathmandu University. He is also associate dean at KU School of Medical Sciences. He is editor-in-chief in Kathmandu University Medical Journal. Also, he is editor-in-chief of Nepal Orthopedic Association Journal, which is still struggling to get a good amount of article. I presume Deepak will highlight on that. Former chairman of Scientific Committee of Association of Spine Surgeons of Nepal, and he was General Secretary of Nepal Orthopedic Association. On behalf of Nepal Orthopedic Association, I'd like to welcome you all, faculties, and personally, I would like to thank for agreeing to be with us to share your knowledge. Thank you very much. With this, I'd like to hand over everything to Dr. Deepak Shrestha, who will be conducting the further courses. Deepak. Deepak, unmute yourself.
Yeah. Am I audible now?
Yes, Deepak, go ahead. You can share your screen. Your screen is not visible.
Thank you, Amit, for your nice words for the introduction. Today, as we all know that today is our third series of our third episode of our series of research for the busy clinicians. And today we are especially focusing upon the how to write the introductions. And then in the last two sessions, we started with the how to choose the topics and how to do the literature reviews and so on. And today's topics are mainly focused on the introductions and materials and methods. And the very important topic is the evaluations of the results using various software, and as well as the institutional review committee, things like ethics and all those. And we have a very pertinent related faculty chairman of the Nepal Health Research Council. So we will use their knowledge and expertise at the most. Are you able to share see my screen?
Deepak, go ahead. Yes, you are visible and audible.
Okay, so I will start today's session with how to write an introduction. Introduction is a very important part of any writing. Let it be our article for the journals, or the articles for the grants submission or the fundraisings, because it starts everything. And unless you have a very good introduction, whatever inside your article or your submission, people will not be interested, or people will not give a priority to listen you or to read what you have written. So just to give an example that how important is the introduction, probably many of us do not recognize these two persons. However, I know how much they are important for the current situation or the current pandemic. Unless we introduce something or the people, it is extremely difficult to understand what we are talking about and how to increase the curiosity of the readers or your audience. For example, these two persons are the person who developed the first vaccines for the COVID-19 from BioNTech, and they are the Mrs. Turesi and the Mr. Ugar. They are the Turkish refugees working in Germany, and they are the person who developed the Pfizer vaccine first time for this COVID pandemic. So what I want to impress is that if your introduction is impressive, and if your introduction is very well written, then the audience will start having a curiosity to go further in your article or in your submissions. So that's why introduction is very, very important. And it acts like a beautiful gate of your job or your work or your submission, so that editors or the viewers or the readers will be interested to go inside and explore what you have done or what you have written. So this is also considered as the gate of an city. And we all know that good beginning is the half job done, and the bad beginning makes a bad ending. But having understood these issues of introduction, we all know that it is very difficult to start writing, and that also starts with the writing introduction. So if you start writing introduction correctly, then you are likely to write other things also correctly. So why do we need good introduction in your article? There are basically 4 reasons to write a very beautiful introductions of your article. The first objective of writing introduction is to establish a warm rapport between reader and the manuscript. The second reason is to stimulate your reader or your target group audience to go through the subsequent section of the article. Third reason is to help the reader to make a positive attitudes to your article or to your work. And the fourth reason is to provide background so that readers can understand your work and appreciate its importance. So unless you have a very beautifully written introduction, probably the readers or the audience may not go in your original result, material methods, and the discussion section. So that's why it's the most delicate part of the writing, and hence it needs a greater attention. If you can write beautiful introductions, then the readers will be interested to read your article further. But most of the journals, they have an instruction to the authors, and they might have a certain, clues how to write introductions. For example, how many words, how many sentences, may not be there, but sometimes there can be a limitation of the words in the introduction session. So before submitting your articles or before you start writing the articles for specific journals, you must go through the instruction to the authors if there are any clear-cut instructions like a limitation of the words or sentences in your article as such, and also in the introduction part. Introduction has got mainly 3 headings. The first one is the background information. You should start with your introductions about the facts which is already known in that particular area, and provide some evidence to support your findings or your facts pertaining to that subject. And the second part of the introduction is after writing the background, you write what is the problem you are targeting for and why you are doing that particular research. And the third part is how does your research are expected or proposed to give a solution. So if you look these 3 parts, it is like a funnel. It will guide the readers from background knowledge to the gap and then the possible solution. So this is also considered is like a funnel. The broader topmost part is the background knowledge or the general information on the particular subject, and the summarizing of previously published or known findings. So this is little broader. And the second part of the funnel is what is the gap in the existing knowledge? That means what is your question? And third is how will your research or your work or your article is trying to address that gap or that problem. So it's like a funnel, broader background part. Middle one is slightly smaller with which should clearly mention the gap between the existing knowledge and your question. And third is possible way of solution by your work. But we may commit some mistakes while writing the introduction part. Sometimes we write very long introduction chapter and very few material and methods and very few results and very long discussion again. Long introduction is not necessary. Known facts or established facts may not be necessary always. So you have to choose the facts which you want to deliver to your readers or your viewers, so that you don't write from A to Z of that particular matter. And it is also not advisable to give various references or the number of references that may not be necessary. And you should not also make various critics or the unnecessary critics to the other works. You simply mention what is the gap in the knowledge rather than criticizing the previous works. You might directly say that this knowledge is not available or these questions has not been answered, rather than criticizing the previous works. And also you have to, sometimes we also make mistakes. We give a list of references to verify or to give evidence of your writings, but sometimes we miss the very important previous findings, and we do not know what is the clear objectives of your work, and hence you do not mention in the introduction. And sometimes we also write the conclusion of your article or your job already in the introduction, which is not necessary, because you just need to raise the question in introduction part and you make a conclusion in your discussion after analyzing the results. And some suggestion and some tips while writing the introduction, that if you are using the abbreviation which is not standard, you should mention into the introduction part with the abbreviation explanation, and after that you can use that abbreviation subsequently in your article. Introduction is written in the present tense, and you should include, as far as possible, recent references or the article of the high impact factor journal or the prestigious books or the standard textbooks, rather than mentioning all the things from the books or the articles. Similarly, you should write the clear sentence aiming the problematic issues and their solution, and your sentences should be attractive, tempting, and comprehensible to the readers. I would like to give some examples of how to write the introductions and how not to write the introductions, with some articles we have published or some articles we have received in our journals. So for example, I have tried to validate the Nepalese version of neck disability index and the numerical rating scales for the neck pain. So if your title is this one, the introductions will start with the background and the known facts. For example, in the first paragraph of the introductions, I have mentioned how common is the neck pain. And the second part is how you measure the patient-reported outcome measurements in terms of the neck pain. So these two paragraphs gives you the background knowledge regarding the prevalence of neck pain and the standard tools to measure the neck pain disability. So this is a background knowledge. The second part is the gap between the knowledge and problem. So present knowledge, the first paragraph says, what is the tool we are using from measuring the neck disability? And the second paragraph states what is the problem or what is the gap. We have a neck disability index, patient reported outcome measurement tools in English version, but this is not available in Nepalese version. So that is the gap between the knowledge and the question you are raising. And the third part is now, how does your article or how does your work trying to answer that gap? So this paragraph may mention that we are trying to fill the gap between the knowledge and the present context. So that means we are trying to validate neck disability index in Nepalese version. So this is how you write the introduction from the background knowledge, gap, and the possible solution. So this is an example how not to write the introduction. So this is one of the article we have received from the Kathmandu University Medical Journal. The heading is Prevalence and the Risk Factors of Hypertension Among 50 plus aged people in semi-urban areas of Nepal. So the authors wants to know the prevalence and the risk factor of hypertension. But what the introduction start is that Nepal is a landlocked country of about 27 million people. This is a known fact, but this is not necessary. If you consider the title of the articles, I think we all think that probably we should not start the Nepal is a landlocked country of about 27 million of people. So if you start with the very basic information from introduction, then you will keep on writing the whole chapter only in the introductions, and that will be too lengthy to read by your viewers and the readers, and they will miss the actual part of your job or your article, which is usually in the results or in the discussion session. So you have to be very comprehensive in the writing the introduction. So take-home message of my presentation is, again, that funnel you have to remember. The broader part is general information on the subject and the summarizing the already known facts, taking some references. The middle part is identifying the gap between the pre-existing knowledge and your question or your problem. And the third part, the narrowest part, is how does your article will address that question or that gap. So again, I emphasize that the writing introduction is creating the funnel so that readers go through the each steps from broad knowledge to the gap and the possible solution. So I thank you for kind attention. Thank you very much.
Thank you very much, Deepak. If you can just stop sharing your screen. There is one question in the chat box. Dr. Susan Raz Paudel is asking. Introduction also includes what has been studied already. Same thing appears in literature review. I think you mean to say in discussion as well. How to avoid this repetition?
Yeah, usually in discussion, it starts with your important findings rather than already published and facts. So when you write the discussion part, do not repeat what you have already written in the introduction. So if you want to compare with your results with the already published facts and figures, that is okay. But otherwise, it is not necessary what you have written in the introduction part into the discussion. That is a very common mistake, that we repeat the results in table and also in writing and also in the discussion. So once if you have written in the introduction part, it is not necessary to write in the discussion part.
Absolutely, Deepak. The introduction is introduction of your subject. Discussion is discussion of your result. So these are two completely different things. The references that you have used in discussion can be used in, in introduction can be used in discussion, but the material that has been used in introduction, or the words or the whatever you have introduced, that should not be included in your discussion. So your discussion should start straightforward with the, my primary finding was this. So, and then you start discussing.
If you keep the facts and figures, what you want to put in the discussion, and if you put the introduction, then probably you will also start writing your conclusion in introduction itself. So that is the common mistake I have already mentioned that you have to avoid.
Absolutely. Thank you, Deepak. That was a very excellent presentation. Then I'd like to request Dr. Ashok Shyam to present on how to write methodology. Ashok sir, you can start sharing your screen.
I hope I am audible.
Yes, sir. Your slide is visible and you are audible as well.
Okay. So thanks very much first the Nepal Orthopedic Association, not only for calling me but for organizing sequential workshops and sessions on orthopedic research. So orthopedic research is very, very close to me. I've been working in this area for more than a decade now. And I think events like this have huge impact, not only live, but people watch it later and remember it later, and as the coming generation to create interest in research and publish more. So thanks very much from my side. So my topic today is on material and methods. So I've been reviewing for journals for a long time now, and I've been editor for a few journals. So I'll share a few of my points that are like personal experience, and then few of the technical things that are already existing that you can find anywhere in most of the books and journals. I'll not go in details into them, but few of the points that I've learned over a period of time from my own experience is what I'm going to stress on more. So for me, material method is the brain of the paper. I consider introduction to be the heart of the paper, the discussion to be the soul of the paper, and material method is what is I call the brain of the paper. So after I read the abstract of any article that is published in a journal or it has come to me for a review, I go directly to material methods and see how well the authors have conducted the study, or whether the study is robust enough and good enough so that the results are substantiated. Without a good material methods, excellent result, excellent outcome paper does not have much meaning, at least to me as a researcher and also as a clinician and a reader. So I believe material method has to be the most robust part of your paper when you're going to publish. I also believe that uh, uh, insufficient information in material methods is one of the commonest cause of rejections of paper. So improper writing, improper description, improper statistical analysis, all these are part of material methods, and these are the one of the most commonest cause of rejections of paper. So pay very, very fine attention to this. It has to include technical description of the study design. So now the entire material method has to be framed in the framework of the study design that you have chosen. So if it is a randomized trial, if it is a cohort study, controlled trial, each trial has a set of framework or a set of guidelines that I'll describe later on. And you have to write your material method within that technical framework. You have to describe the methods and the tools that you have used. And the third part is the statistics that you have utilized in the material methods. So like I said, study design is one of the basics of writing material methods. That is, it defines the entire format of material. So certain things are common across. I mean, you have to give the patient population details, you have to give certain criterias and the operative details, but every design has a proper format. That's why you have to establish your study design beforehand and then write your material methods accordingly. The entire focus on selection of study design and the writing of material methods is to convey to the reader how you have tried to reduce bias in your study. Okay, so that is one of the major pillars of material methods. You have to display and present to the reader, to the editor, to the reviewers, what methods you have tried to reduce bias. And that is where the selection of study design comes into play. Let's go into certain details. This is a common question that a lot of postgraduates pose to me. When do I write material methods? So I believe each section of an article has to be written and rewritten multiple times at various various timeline in your study. So I believe material method have to be written before the study is begun, and it has to be verified by a statistician also. You have to include a statistician if it is a really good study design and you are having multiple groups and things like that. Include a statistician. Second is you have to revise the material method whilst you are doing the study. Because while you're doing the study, you'll find there are certain practical aspects that you missed out, and you have to add those things in your material methods. And of course, after you have written the results, this is very important because a lot of things in material methods have to be contextual to the results. Not only contextual, it has to be logical and chronological to the results. Okay, so it has to match the results both in logic and chronology. So you have to rewrite it after you have your complete results again. So I divided into different paragraphs. Like Dr. Deepak mentioned, there are 3 paragraphs for introduction. This is not conventionally mentioned, but we can divide the material methods also in 3 paragraphs. Basically 4 paragraphs. So first paragraph is where you define your population, whether you define the ethical approval status. This is important and has to be mentioned nowadays for every paper to be submitted, that ethical clearance has been taken. Temporal and spatial distribution in terms of when the study started and when it has ended, and what kind of, if a geographical area is involved or not involved, if it is done only in one hospital or multi-centric. So all those details comes into the first paragraph. And one of the most important points here come into play are inclusion and exclusion criteria. I believe these are the 2 things that are very, very important in any study design. And these are the 2 things that help in 2 very important concepts that I'll come to in very quickly after these slides. So inclusion criteria, as you understand, conditions that must be met to allow the participants in the study. They are based on a research question. For example, for high flexion knee design, when I compare to a standard TKR, I include only patients undergoing TKR for primary osteoarthritis. So I exclude a rheumatoid patient. I exclude any other pathology of the knee joint. I include only knee osteoarthritis. So it standardizes my patient population. Second is exclusion criteria. Again, this is determined where the participant may not be allowed in the study. Again, based on a research question. So you exclude patients that introduce confounding or bias in the study. So I'll give an example here. There are a lot of times students and even clinicians confuse inclusion and exclusion criteria. Okay, so the thing is that inclusion and exclusion criteria, they define the generalizability of your study and they help in reducing bias. However, you define the inclusion criteria first. Okay, so you define your inclusion criteria first. say it is primary TKR following primary osteoarthritis. Okay, so that is your inclusion criteria. So your exclusion criteria is not rheumatoid arthritis. Your exclusion criteria has to come out of the inclusion criteria population. So out of these primary osteoarthritis TKR, you will exclude patients having more than 20 degrees varus deformity because they'll come into complex TKR, or patients having hyperextension deformity. So you will exclude from the included patients. The inclusion and exclusion criteria are not mutually exclusive. The exclusion criteria comes out from the inclusion criteria. So this is a very, very common mistake that people do. And if there is still confusion about this point, I'd like to take questions later when the my talk ends. So like I said, these are the two factors that standardizes the population, reduces the bias, and makes clear to a reader, not only
Did me down the money now?
I think we have lost Dr. Siam presentation.
Deepak, I think we have lost him.
Yes.
Yeah. Okay. We can wait just for a while, and then if not, then I can start, and then he can again continue his presentation. Lines and go.
Meanwhile, if there is some question, I think we can discuss on that.
Yeah, I was looking at any question, but there are no question actually. Deepak, if you allow me, I can.
Okay.
I can start my presentation, and once Dr. Ashok comes back, then we can again.
Sure. Meanwhile, we lost signal from Dr. Siam, so hope that he will rejoin again. For the sake of time,
He's back, Deepak.
Yeah.
Okay.
Sorry about that. I just got disconnected.
Yeah.
Okay,
Yeah.
so I'll again
you can continue,
share
Dr.
my
Ashok. Yeah.
screen. Yeah.
Yeah.
Okay, so I hope I was clear in my talk on inclusion and exclusion criteria. Second paragraph then comes on basic demography, where you define the age, gender of the patient, the common pathology. If you're doing it on a fracture, then you define the fracture distribution, the classification of the fracture, the classification of whatever pathology you're looking at. And then lastly, the operative and the experimental procedure in detail. While defining the operative procedure, these are the few points that I have seen in my experience that has to be provided in enough details. Okay, so you have to provide the operative detail procedure in detail. However, you can use references of other papers and reduce the description that you have to provide. Describe the part that is important for your paper or for your subgroup analysis. So keep those points only in your description. Also write any variations or any kind of improvisation you have done during the surgical procedure, and in number of patients that those improvisations are needed. For example, you had a avulsion of MCL during TKR in 5 patients, and how did you tackle it using a screw or a staple? So mention those variations or intraoperative complications that you face during the procedure. and describe the post-op protocol in detail. Okay. You need not mention the pain medications or antibiotic medications if it is not a outcome measure in your study, but you describe the post-operative protocol in details, including the follow-ups. Now, validated outcome measures are one of the other pillars of material method that comes after you finish describing your operative details. Primary outcome, one of the most important outcome that you're looking at. So while examining the effect of high flexion design of TKR, knee flexion is the primary outcome. Okay. Secondary outcome or outcomes can be multiple of them. Even primary outcomes at the time can be multiple. So you need not only see the range of motion or the flexion, but you want to see the survivorship also. So it has to be longer study, but that we can have two different primary outcomes also and multiple secondary outcomes. So it is defined by secondary outcome is defined by your primary outcomes or other important outcome measures that you are measuring during your study. Now, how do we classify the outcome measures? So I have made it very simple and very comprehensive. For us in orthopedics, we can divide the outcome measures into these four headings: clinical, functional, radiological, and patient-reported outcome measures. At times, we may not have radiological measures, but clinical, functional, and prompts will be there. So you have to select. Clinical means range of motion, the pain was, and any special test that you are including in that particular area. Functional outcome is related to that particular joint or area or bone. So for example, Oxford knee score and other, these are related to function of that particular body part. Okay. While patient reported outcome is concerned with the entire patient's function as a whole, as an individual. So that's the difference between functional outcome and prompts. Radiological outcomes, of course, important radiological outcomes you have to select depending on your study design. Follow-up protocol is, like I said, I've stressed earlier also, you have to define in detail what is a follow-up protocol, at what points patient is going to come for follow-up, each follow-up, what are you going to measure? Okay, what outcome measures you are going to measure from these four at each of these intervals of follow-up? Okay, and then you have to define the endpoint of your study. Statistics has to be the last paragraph of your material methods. You have to give the complete rationale and description of statistical methods, especially sample size, descriptive data, how will you analyze. So for statistics, you need to take help of a statistician. And second point I'll make is take help of the guidelines. So these are the few points that you cannot miss while you're mentioning in the statistical paragraph of material methods. So you have to describe how you are controlling the confounding variables, how you are controlling bias, how you are defining the subgroups, and how you plan to analyze them. So this is also again a part of statistical paragraph, and how the missing data, not only missing data, how lost to follow patients are addressed. So this you have to mention in this statistical part. Like I mentioned, guidelines are available for writing papers. Most important of them are consort and stroke guidelines. Consort guidelines is for randomized controlled trials, and stroke guidelines are for observational studies. So you can take help of these two guidelines. They're very, very comprehensive. This is a consort checklist for material and methods, and you can find a lot of things that I've mentioned already and a lot of new things depending on the study design. Like I said, study design is what will help you format your material methods. So this is a consort for randomized trial. These are the stroke guidelines which will help you for other observational studies. So you have to focus on study design, inclusion, exclusion criteria, outcome measures, tools and methods of data collection, and statistical analysis. Why is material methods important? Like I said, it is the brain of your paper. Okay, it is one of the most important points for acceptance and rejection of paper. read by reviewers, editors, everyone. Reproducibility is one of the most important factor of any research. Your material method has to be written in detail and in such a way that anybody reading it, any researcher reading it, should be able to reproduce it. That is the main aim of your writing part of material methods. Anybody reading should be able to redo your experiment and reproduce the result. If people are unable to do your follow your technique, follow your method, they will not be able to produce research on it, and the research will not be then cited more and not receive the place it deserves. And last is material methods establishes the applicability of your research in clinical scenario. If your material method is robust, it's good, then your results are applicable to a vast clinical population. Thank you very much from my side. That's all.
Thank you, Dr. Shyam. Can you make Dr. Dipesh Tamrakar and Dr. Jayasa also co-host, because they have to present their papers? And then, are there any question to from faculties to Dr. Ashok Shyam? I have a very simple question. You know, sometime you know, some people, they write you know, demographic findings in methodology section, and sometime in, you know, in the result section. So what is your take on that? Can you just clarify when to write in material method section the demographic findings, and when to write in the result section?
It's not when, it is what. What to write in material methods and what to write in result section. So I think basic demography has to be included in your material methods. So age, gender, if the site is important, that point, the basic demography there. However, if you're doing a subgroup analysis, okay, if you're doing a subgroup analysis, you have to write that in your result section also, and then present your results in subgroups. So I believe demography primarily, if you're not doing any subgroup analysis, then primary demography remains in the material methods part. Otherwise, this is how you write. Like I said, material methods and results have to be contextual to each other. So that's where you can customize when you're writing. Yeah.
Okay. Deepak, can you take that question and ask to Ashok sir the question in the chat box?
Yeah. So there is a question from Mr. Subhas Karna. How to estimate sample size, particularly when we do not have an incidence prevalence of conditions under study?
That's a very simple question. You do a pilot study.
Yeah.
You do a pilot study, and based on that, you estimate the sample size. See, sample size is a best estimate. Okay, it's not a hard and fast rule. It's a rough estimate so as to support your statistical analysis and to support your p-value. Okay, and to define the power of the study. So it is an add-on thing to help you support your statistical analysis, right? So you do a pilot study and you do that.
Yeah.
Okay, somebody is asking on, can we elaborate more on operative details in study, or just have to mention overview of the procedure? So it all again is contextual. If your study is based on variation of operative procedure, okay, if your study design is, suppose you want to study the say different approaches in TKR. So you want to study the minimally invasive approach and the standard approach. In that case, you have to elaborate on the approach part. You don't have to then elaborate on the what cuts you're taking and how you're making those. That's a secondary part that you can give a reference to. But you have to describe in detail the part that you are trying to study. Okay. But if your study is on intramedullary nailing of femur fracture, there is no need to describe the technique in detail. You can just mention the nailing was done using this kind of nail and this kind of entry point and this many patients. You don't have to describe the entire procedure at all. So it again depends on what you are trying to study.
Yeah. I think Dr. Ashok is rightly said that it is contextual, that what your problem and what is the question you are trying to answer. For example, if you are trying to answer the outcomes, then probably you may not need to describe the details of the techniques. But if you are comparing the different techniques or you have innovated some new techniques, then probably you need to describe in detail, even the minor details also. I would just like to use the expertise of Dr. Deepesh also. So he's already here now. So because most of our clinicians are, a little bit scared of that. I don't know how to measure the sample size, or my sample size is very small. So how do you try to answer all these, the curiosity especially from the clinicians?
Thank you, sir, for the questions. Actually, sample size depend upon your research question and the study design. As Sam sir was also mentioning, your research study design depends upon your research question. Similarly, according to your study design, and sample size should be calculated. Like usually we do for the prevalence for PQ by L square. This is a common one, but it's not for everything. It's for the particular study design, either cohort or cross-sectional. But if you want to do the clinical trial, then it should be based on that one thing I like to make. And if sometimes if prevalence or conditions are not available, then you could do pilot study, or sometimes you take the best estimate you could put in a such a way that will give the maximum sample size, so that it will cover everything. Because the main concern is whether the total sample you collected would have the enough power to do the statistical analysis or not. That's a major concern to find out that how much sample size is required for the study. So on the basis of that, we calculate, and just take home message is, according to your study design, sample size must be calculated, and always the statistician or someone colleague who could has idea of that could help on that. A lot of software also available.
Yeah, we will discuss more on this issue in our discussion session also. So for the non-statistician like us, so what is a very simple way to think about the sample size is that if you're trying to measure the small difference, then you need a big sample. And if you're trying to detect a big difference, then probably you need a small sample. So that is, I think, in the layman term, that is how we think about the sample size.
Or the vice versa is also true. If you have a small sample, you can detect only big difference.
Yeah.
So one of the things that Dr. Deepesh mentioned, I'll make a quick point out of it. He said the best estimate. Okay. So one of the simple methods that I found out and have been using for detecting best estimate for anything in orthopedics is taking an average of number of patients that have been used in published papers. So I'll give an example. Proximal tibia fractures, plating. Take out last 20 papers that are published, most recent last 20 papers. Take an average of sample size of all those 20 papers, and you get a best estimate. It's a very rough, but it's a very practical method and a very simple method for you to, in a busy clinical practice, this is a method you can use very easily. So, and you'll come to know that you required only 45 cases of proximal tibia plating fractures for your sample to be good enough.
Yeah.
You got my point? The most recent 20 papers, especially published in PubMed. Don't take from Google at all. I mean, journals also matter, but take from PubMed. That's a very, very simple method.
Thank you for saying a very good tip.
Deepak, there are a lot of questions coming up. I think we can take this question at the end of the session. Can you continue, because we have to finish the talk?
So we need to now move on. We will discuss the further question in discussion session. Now I'd like to invite Professor Amit for his talks on how do I prepare the pro forma for the study. Dr. Amit, please.
Deepak, is my slide visible?
Yeah, visible, clear, and loud. Yeah.
Thank you, Deepak. I am always a proponent of saying that all clinicians must learn basic softwares, which will make our research life much easier. So, and this was the theme of whole research for busy clinician. We have taught a lot of softwares, and today I'm going to talk about a very common software which can be used for collecting your data of your patient. So let us start with proforma, what it is. Proforma, the simple definition of proforma is it is a form with details. So any form which has detail of your patient, they are known as the proforma. So there are basically two types of proforma. The classical old one is the paper proforma, and currently many people are using electronic proforma. But if you talk about the electronic medical record system, what we say EMR, they have a fixed variables to be recorded. So if you want to record a variable that is pertinent to your patient, which may not be possible in a fixed EMR that is given by some of the hospital even in our country. So probably if you are talking about a prospective good study, it's always good to make your own electronic proforma as well, because at some point of time the paper data that we have already collected has to be converted to electronic for the analysis purpose. So also I would say that the electronic entry may not be possible all the time, so it is always better to have a paper also available whenever there is some situation or instances when you cannot record electronic. Make sure that you record in paper, and as soon as you have available electronic recording, convert that to a electronic record system. So what I'll say that do not choose only one. You always try to have combination of both when you start recording your cases. So how I personally do it, again, to emphasize what Dr. Ashok was saying, a brilliantly and well-worked research method is very, very important before you start recording your data or making a proforma to record the data. So what I do personally is all the parameters that I'm going to measure in my research, which is mentioned in the methods, are used to make a paper proforma. So this will be my paper proforma. This is one of my research, undergoing research, and the paper proforma has been prepared. And then I convert into Google Forms. So, there are so many other recording, software available in the internet, but this is probably one of the very versatile and freely available to all of us. The only thing it requires is a Google address and the Gmail everyone has to open so that they can access the Google form. So this is a small video I'll show you. This is a 5-minute video how how I make a proforma for my research.
It's 20 hours.
So first I open the Google Drive. So if you open the Google Drive, it will open the Google Drive, some of already published, prepared. If I'm preparing a new one, I open a new and go to the form. It will automatically open a new form, which is untitled. And I split my screen and then open the paper proforma. So in one screen, I have a paper proforma. On the other side, I have a Google form. So I start writing the title first. So that is my title. And if you click at the top title, it will automatically copy it. Then you start, putting your all the variables of your proforma, the paper proforma, into a electronic proforma. Make sure that you make all those things which is compulsory as a required one, like in the blue one, it has to be made compulsory so that no data is been missed when you submit your data. So these are the very simple one, name, age, sex, and the contact number of the patient. Probably these are very, very important for follow-up. Then you continue, you convert your paper proforma into the electronic proforma. You can change the type of question by clicking into the types. Here, earlier it was a small description. Here it was a multiple choice. If you start working on it, you'll find out that this is a very versatile and very easy to use. So we'll come to the time elapsed from the day of injury. Again, this is not a multiple question. This will be a change this multiple question to a, I'll change this multiple question to a short answer. So I can write a short answer to that, 7 days or 10 days. Then coming to the side of the injury, you can have a checkbox or multiple question, and then have a pre-filled, sorry, there is something has gone wrong. Okay. So pre-filled, you can get pre-filled options also. So inside of the injury, you can write right, left, or both. That is what we are going to do. Oops. Somehow my video is not running properly. So I have just skipped some of those. So you keep on, you click the plus, it will keep on adding your question, n number of questions, the multiple question you can add, there is no problem with that. So if you come to the, I'll just skip again a little bit, so that in the interest of time, to show that how you can, this is the addition of the ALCA score. So ULCA score I'm adding. So what I have done here is I start with the ULCA score pre-operatively. So pre-operatively, you can measure before the surgery. That is why it is required. But if you talk about the follow-ups, how to use it in the Google Docs, is if you write a ALCA score in 3 months' time, then what you have to do is you have to uncheck the required one. Because if you do not uncheck, until unless you put your ALCA score in 3 months, it will not be submitted. So make sure that those parameters that you are going to use in the follow-up period, it must be unchecked. That is the only tip I would like to give you, because otherwise this software is very, very simple. Again, I'm adding ULCA score at 1 year. So I have to uncheck so that it is not compulsory. So it is not mandatory to put at the time of submission. So again, I have to uncheck. That means it is not required. So once you have already, converted your paper into electronic data, then you can see that you go into the view one and you will find out that how the form will look like. So this is the form, how it looks like. And I'm going to fill the form, age, then 50-year-old, then contact number, road traffic accident, 7 days, right side. It just click. It becomes so easy and simple to submit or to keep record of your patient. So I'll correct and write, CC distance, type 4, ALCA score. See that asterisk means that is compulsory. So in the later one, there were no asterisks and it was not compulsory. So once you have submitted, you can go back and see that one response has already been submitted. You can go into that response and click the Excel logo and it will create an Excel sheet automatically. So Excel sheet has been created automatically. The data has been converted into the Excel sheet. And when the patient comes to you in 3 months, 6 months, and 1 year time, you can find out the same data on Excel sheet, and you can add the follow-up parameters, whatever may be. So you, at the same time, you have all these data recorded into Excel sheet, and probably Dr. Tamrakar will tell us and show us that it will be very easy to convert from Excel to SPSS, and you can export this Excel sheet into your desktop so that you can use them. So this was a very simple one, and then once you start trying it, you'll learn that Google Forms are one of the easiest way to create an electronic record of your patient. You can use as much as question as possible or as much as you want, and you can record all the variables if you know how to use them. So to conclude my presentation, I'll say that a comprehensive proforma has to be prepared before you start a research. And the proforma has to be based upon your material and methods. So those parameters that you are not going to use in your result or not mentioned in your methodology should not be included in your proforma. For example, if you are not using age, sex of the patient, then it should not be collected in the proforma. That is a part of the ethical issues in data recording. I will suggest to have both paper and electronic version of the proforma, because we all know our context, electronic version may not be available everywhere. So you convert, you take the data into paper and as soon as possible, you convert into electronic. There are various forms and software available. You can use anyone, but I would say that Google Form is free of cost and it's very easy to use. The only limitation of this Google Form is you need to have a Gmail account. Thank you very much, Deepak. Deepak, you are muted.
Oh, sorry. Thank you very much, Amit, for your nice presentation and the informative demonstration of how to prepare Proforma in the Google Form. You rightly said that there are many software which is freely available, but just because of lack of knowledge or a little small experience, a little bit of experience, we are not taking the best use of those available software, which is freely available. There's one question from Dr. Susil. Can we prepare Proforma that incorporates a wide range of variables and use it as a registry for more than one study or article? Amit, you are.
Yeah, thank you, Deepak. I think that can be considered as a breach of ethical conduct of research. So you cannot collect all the data in one Proforma and make multiple papers out of that single Proforma. So whatever your material and method says to collect for that particular Proforma, you can use only those parameters or those variables to collect the Proforma. You cannot collect everything of your 200 patient and keep on making research out of that single Proforma over next 5-10 years. So that is not unethical. You cannot do that.
There is a clear nomenclature for those kind of things that is called salami cutting. So you take everything in one go and then publish it in the bits and pieces, like you make a cuts in your salami. So that is considered as unethical in terms of the research and in the article publications. Right now, I don't see any other question in the chat box. So if there are any, we will bring it in.
Deepak, can I request Ashok sir to make co-host to Jay Shah sir as well, because he'll be presenting and then Shyam sir will.
So our next talk is in fact related with the ethics of the researcher, ethics of the the research itself. So if Jaysa sir is ready, I would like to request him to give his talk on institutional review committee format, why it is necessary to take IRC approval. Jaysa sir, please.
Yeah. Is it okay? Can you see the screen?
Yeah, we can see. You can keep into presentation mode.
Okay. Thank you. Okay, thank you, Amit, and thank you anyway. This is quite energetic guys you are. So it's good to see that despite being busy, we are here. So I'll just start with this disclaimer that this is not the first time I'm presenting some of the materials. So I've done some before as well. So that's a disclaimer for that. Next will be, this is basically today this is two topics I'll be covering. One is the ethical approval, why it is necessary. And then I will just briefly discuss what is the format of the proposal that you prepare to get approval from the ethical committee. I think Amit has already introduced me, so I don't need to read this slide basically. So what is I'll just go to the topic itself. So why ethical approval is required? So we all know that there's lots of consequences of doing research without any prior approval. So basically what we see from the ethical committee point of view is always to ensure the safety of the participants. And if there's any risk, this is the researcher's responsibility to minimize it as much as possible. So it should be less harm, more benefit, always. At the same time, what we do in the ethical committee is we are also very sensitive to the requirements of researcher as well. So just keep on balancing. So fulfill the requirement of researcher, at the same time, ensure the safety of the participants. So this requires that all studies on human being, any kind of a study, it has to be approved prior to the start of the research itself. So before we collect any data, we have to have a approval. So you can plan your study before approval, but you can't collect the data itself. So it has to be approved. Same time, like what you see is lots of funding agencies. They won't fund you unless you have approval. Same thing like the publications. Almost all the journals these days, they would require you to have a prior ethical approval. And then only they will publish your or accept your article. So this is the need probably. And sometimes lots of people will say, whether this study is very simple study, this is only a case report, this is only a simple review forms. And if you're not very sure, always, if you have a local committees, consult them. And if there's a waiver, they will simply waive you from the research, or still this is valid. Lots of ethical guidelines are there, many. But most of the guidelines were created after World War II. And most famous what we see is Nuremberg Code trial, way back in 47. And in this one, this is also called doctor's trial. And this was a trial when almost 23, 24 German doctors were put on trial, and 7 were given death sentence. So this is also called doctor's trial. Similar trial was done in Japan as well. It's not very famous. And this trial came out with the codes, 10 codes in 47. But what we see again, the Tuskegee studies, very famous study. It was sanctioned by the US government, 32 to 72. Went on for 40 years. It was done in African Americans, syphilis patient without any treatment, just to see the natural progress, funded by the government. And we know that syphilis, penicillin came in the market in 40s, early 40s, 48, 49. But these patients were not given any treatment and considered. So only after 20, 30 years, Bill Clinton, he apologized. So in what we see in ethical committees point of view and all the researchers, we have to be familiar with the human rights issues as well, general concept, the CM's guideline, the Council of International Organization for Medical Sciences. These guidelines goes beyond human research, like so epidemiological study on the prisoners, study on the vulnerable population. So it has separate guidelines. Declaration of Helsinki is the main that is concerned with the clinical research on human being. This is adopted by the World Medical Associations. It started in 64. The most recent edition is 71st meeting in 2020. And this in this one, basically what he gave out is what is the patient-physician relationship. So this study, I think all the researchers, we have to go back to this certain guidelines, have some basic idea. And all this is based on basically Belmont's report, which was in 79. Basically, what it says is you have to have at least follow the principles of guidelines. Basically, it's a respect to the participants, protect them, give them autonomy, beneficiency, that means benefits should be more than harm, at the same time also justice. And then also we have the Nepal Health Research Council guidelines. So these are the certain guidelines, all links are there, so you can go to online very easily. On the waiver part itself, lots of these days we have a researcher that will say whether this is only simple study, only service performance, whether we need a approval or not. So I just prepared this slide based on that simple topic. What we have been thinking is physicians have always been traditionally thought that we are the judge of the best behavior, which is not true probably in a given scenario. And sometimes we think that we have been treating this patient for so many years, so what I can't write a paper on that? You can't do that. Simple reason is because the norms society needs, the moral values changes. And simple example would be like, say, for a simple example, slavery. It used to be common practice. You can't do that. Like women allowing voting. You can't say this, oh, the woman can't vote. So the moral changes, and this is the reason why ethical approval changes as well. According to the society, according to the country, according to the needs of the people. Normally what we do from ethical committee is sometimes we exempt it. For example, you have the service reviews. Or it's audit simple. The audit of the existing data, which may result in improvement. You are not collecting anything, personal data of the patients, and this is meant to be only locally used in your institute. Then probably don't need it. But again, if you want to publish it for the bigger mass or the bigger audience, then probably you need it again. So basically, again, even if it's exempted or you have been waived, still you're required to have fulfill the basic consent. Like you can't collect the private data, sensitive data as well. If it is funded research, then you can't do it. Again, vulnerable populations, you can't do it. And vulnerable population means like the children, the comatose patients, or who can't give consent on their own capacity. So this kind of research always requires prior ethical approval in an added form that how you take the consent for them and how you safeguard their rights and benefit. One common thing is like say that wherever you can have it for the knowledge which is already public in public domain. For example, tomorrow you are going to do a study on the data already published in the newspaper. I say Kantipur. In the last 5 years, they have how many they have published the road traffic accident RTA in orthopedics. So probably then you don't need a approval for that data. This is already published, public domain, anybody can access it. And this data do not really take into consideration the personal data as well. Same thing, sometimes we do a study based on national survey. It's already done. Then we take a certain portion, then we analyze it. Then you don't need a ethical approval. So there are certain examples of this one. But again, even if it's exempted, still it requires minimum standards of ethics to have it followed. Informed consent, benefit not to harm, continuity, it's all it has to be there. Ethical review procedures, what we do basically is all the time from the ethical committee point of view, we always see that dignity of the participants is maintained, their right is maintained. At the same time, universal ethical values, like we talked earlier, Helsinki guidelines, UM's guidelines, those are already fulfilled. So when we review the proposal from any researcher, we see that these features are already incorporated in the design itself. This is a very crowded slide, so I don't want to read it. Basically, what you can do is simply go back to the net. You can, it's very easily available. The World Medical Association Declaration of Helsinki. The latest update is in 18. It's a very thorough document. It has almost about 37 points, 12 sections. So it has all these sections divided. Like what is the risk benefits, what are the vulnerable populations, how do you deal with them, scientific requirements of research protocols. So these are all very clearly written over there. Even sometimes use a placebo. So when you can use a placebo. So these kinds are there. What are the post-trial provisions? So in the post-trial provision, lots of time with the clinical trials. So when we look at the proposal itself, not only during the study, but the study design also had to mention what you will do after the trial. So if it's not mentioned in the design itself, then we won't approve it. Same thing to go to the registration or publication of the data. So if you're doing a trial, it has to be registered. In Nepal, we still do not have it. Research Council, they have recently started, but it's still not very functional. So this is the reason what we see is in Nepal, we have very small number of clinical trials. If you want to do it, you have to get it registered. If not in Nepal, you got to go to international platform. So Research Council is doing it, but it's still not functional. So sometimes they are using this Indian platform to do that. So I don't want to go into too much details of the ethics itself, why ethics is needed or what ethics is not needed. We all know that it's required. The format of proposal itself, I think we talked earlier, the pro forma, the introduction part, the method part, and in this proposal format, when you apply for the ethical review or ethical committee approval, and that time we have to have this already incorporated in the pro forma itself. So I'll just take an example of this, my own ethical committee review form, which we have modified lots many times. And it's quite comprehensive. And so also the ethical committees view that we not only approve it, we also, because we are a teaching institute, university. So we, at the same time, we also teach the faculties, the researcher, how they can apply it, how they can improve their capacity as well. So in this one, what we'll see, this one is, you can go on this our website. So this is the past website itself. And this one is ethical committee. So we have this form already there. So in this form,
Yes, sir. Yes, sir.
Yep. Yep.
We cannot see where you have gone. You have to minimize and then share your screen to show what is there in your desktop, because the link will not work in case of Zoom.
Okay. So what you can do is simply, like in this one, is it okay now?
No, sir. You have to stop sharing first.
Yep. Okay.
I think it's somehow it's stuck up. It's not, going off. You have to stop sharing.
Is it okay?
Now, yes. Now, if your window is open in your desktop, then you start sharing. Share screen down button.
Okay, I know. So this is basically because I was sharing the window only. So now I'll share the full screen, then it will be easy. So now you can see probably. Is it okay now?
Yes, sir.
Yeah. So for the format itself, I'll just give you one example that every ethical committee, they have their own format. But basically what I'll go is the basic format itself. So basically what we do is in our ethical committee. So in this one, this is the ethical committee we have. And at the same time, this is the format. So I'll just take out this form and discuss on this one. So it becomes easy for us to comprehend what kind of proposal we need to be preparing for the approval itself. So I think it's visible, yeah? Amit, can you see?
Yes, it is visible, sir.
Yeah, okay, good. So this kind of a bit different for all ethical committees. But what we see is when you prepare the format, where you are applying depends on that format itself. So before you apply to an ethical committee, just go on their website, see what they demand, just like journal article. You have to read first their author's guideline. The same thing is for ethical committee as well. So this is the first section, instructions, how to fill the form itself. 10 points over there. Then we have the checklist. And all these checklists have to be completed before you move forward. And then we have this. So this form is basically for all, like say local nationals, or you have multi-centric studies, or you have foreign participants as well. So this form is applicable to all. So if you go on this one, basically what you are required is, when you fill the form itself, full name, designations, all these addresses, even your citizen ID, everything. So these are all required in all ethical committees. So if it's a Nepali national, you have the citizenship form itself. If it is a foreign national, they have their passport number as well. So this is to safeguard the requirement of the participant itself. Then again, this study was approved by certain departments or certain university. The name has to be there. Their address has to be there. Then who are the co-investigators in this research? So there again, their name, designation, institutes, mobile number, country ID, it has to be there. So keep on filling it up. Then comes the title. Like I said earlier, in last program, we already discussed what is a good title. And just to help the researcher itself, we have this designed already here. It will be short, no waste words, no abbreviations, should align with the objectives, methods, and outcome. What Deepak mentioned earlier, introduction. So what we have done is this form is, this is the already guidelines over here. So write an inverted triangle. Ideal 3 paragraphs, global view, regional view, local view. And this is very, sometimes what we see in lots of proposals, there are hardly any local views. Lots of publication we have in locally. So all this proposal has to be in the local context as well. So lots of citations are from international journals, high factors journals, but very few citations from the local studies. So rational has to be, again, then what is the gap in the studies, what are the controversies, and then with the rational. So lots of proposal, they are missing the rational itself. They have very good aim and objective, but no rational. So justification of the study, very nice aim, but it's not justified, it's not reachable, not doable, not feasible. So if it's not feasible, not doable, then we, no matter how good the study is, we won't approve it. So rational and relevance has to be there. And what we do in our form is we have just, even the word limit is over there. The aim is to teach them that this has to be in the format of journal itself. So later on it will be easy for them. Method section, again, same thing. So this in this pro forma format of the ethical approval, the method section, it has to be detailed enough to people can reproduce it. They can validate it. They can further extend it. And for this, it has to be have very clear-cut objectives. It's general, what is general objectives, specific objectives. Again, we have this all these guidelines over there, no abbreviation over there. It has to be measurable action verbs, design, place of a study, site, duration of study, sampling technique, sample size, all these things, what variables you are studying it, what is the inclusion criteria, exclusion criteria. Because unless you have this one right now in the proposal itself, when you collect the data, then you are missing something. And when you write a paper, then you can't do it. So this has to be all incorporated in the proposal itself. The process details, where it was done, when it was done, how it was done, by whom. So all these things has to be clearly written in the proposal itself. Not very detailed, but all the items has to be there. Let's say the data collection, tools, performa, like Amit mentioned earlier. Lots of time what we see is lots of performa is too extensive sometimes. Lots of things are there. And lots of time we have a hard time to convincing the researcher that you can't do it. Because ethically, this is complete, not like, so for example, sometimes you are telling the telephone number. If you are not following up your patient, then why do you need telephone number? There's no reason. So unless you have follow up a study, then you need a telephone number, they need the address. You don't need their address. So this thing all has to be there. The dummy table, this is our, because we are an institute, university, we have to teach them, we demand that you have to have a dummy table as well, based on a specific objectives. So this will tell them what tools they are using, what statistics they are using, data processing software, what they are using, tool, what they are using, data management. Lots of time what we are missing out is in the proposal itself. How do we manage the data? How will you store it? For how long? Who will have access to the data? So all this thing has to be mentioned in the proposal itself. Lots of committee, they have different rules. What we do at our institute is all the data has to be at least saved for minimum 5 years, accessible for 20 years, and it has to be password protected in the institute itself. Who will have access? Only the ethical committee in the institute. Even the researchers, they don't have access afterwards. Once you complete your study, data has to be deposited. So you can't keep on data with yourself again, keep on disseminating it. You can't do that because you can disseminate the articles, but not the data itself. So this thing, all these things has to be in the proposal itself. Very carefully, you have to design this vulnerable population, conflict of interest. And it all has to be declared in the proposal itself. Do you have any conflict of interest in this one? Lots of time what we see in the proposal itself, you have so many listed articles. Nobody can read those ones. So what we have demanded is at least not more than 10, because nobody is going to read more than 10. Up to 10 is more than sufficient for any proposal. It can vary for different committees. And what we normally demand is similar to what Deepak mentioned earlier. 1/4 has to be within 2 years' time. 1/4 has to be within 3 to 5 years. Again, this is again the same thing, like it has to be different styles. And all the citation has to be hyperlinked so people can verify it where you have done it. So this thing all has to be clear-cut mentioned in the proposal itself when you design it. Then you have different information. So like, again, budgeting. Lots of time we clinicians are very poor in making the budget itself. But unless you give the budget to the committee, you can't approve it.
I think you need to little bit.
Yeah, is it done now?
Yeah.
About 1 minute or so. So this is has to be there. Then what equipment, biosamples. So this thing all has to be clearly cut mentioned over there. Any foreign researcher involved or not. So this is all sample format. Then you have this, what kind of consent form you'll be using, how you'll use it, in what language you'll use it. So these things all has to be clearly written in the format itself, performa, its ethical form itself. So basically it was done. So now what you can see is, now I'm already done. So this is ethical review already done. So some of the form is already done. So now there's some of the resources that you can keep on the ethical reviews itself. WMA, Belmont report, COM's guidelines, Pope guidelines. And again, when you're publishing it, then ICMJ guidelines, locally research council guideline, New York code, district studies. So these are some of the resources. I think I'm done. Thank you, Deepak.
Thank you, Jay sir, for your elaborative presentation on the IRC and its importance and how to submit IRC application in reference to pattern. I think this can be example for the example for the any other institute also. There is no question in the chat box, but I'm sure that there will be lots of queries from participants in discussion session. Now I would like to request Dr. Deepesh to present his talk that how I use SPSS for my research. Dr. Deepesh, please.
Okay, thank you.
Thank you very much, Dr. Deepak. I think we just reading back, like we did, we discussed it.
So what are the keep in presentation mode.
Okay. Sorry. We discussed like, because what I'm going to discuss also depend upon the what has been discussed previously about the from the our analysis, like the spaces that we are going to use depends upon the what we planned in the performa, how we collect data, and what we make up what we plan in the proposal, as well as what we collect in the performa. And then for the result, then we require to do the data analysis, and for that we use the statistical software. So I'm going to discuss about this SPSS on this. But before going to the discussion about the SPSS itself, just I like to review the few terminology or few about that is especially helpful during the analysis part, few terminology about the statistics. Like we had already discussed about the variable, what is variable, and there it can be categorized into two types. Sometimes we call qualitative and quantitative, or categorical or numerical, and that is also further category, because these things determines later also that determines what kind of analysis that we want to do, especially bivariate or multivariate analysis or the graphical representation. All this depends on the type of variable or data that you generate from that. And categorical also, it's further subdivided into nominal and order, and these are not the actual count. This is the qualitative data. And ordinal is which is in order, like rank or stage or disease stage or level of educations. These are also not the count, not a number, but there is certain order on this, like if, class 1, class 2, class 3, class 4. There is an order: education, primary, secondary, or tertiary, primary, secondary, higher secondary, bachelor. This has got the order. So these are called the ordinal. And numerical also, like we in mathematics, we discrete or continuous data, or discrete is the count value or integer value, like number of pregnancy, number of days, 6 per year. These are the example of the discrete data. And continuous is which has got the decimals in the one. And sometimes these are also divided in the scale of measurement. This first two are the categorical one, nominal scale and ordinal scale, as previously discussed. And the continuous data are also sometimes we see the term like interval scale or ratio scale. The interval scale is where the difference is the actual difference is there, but there is no absolute zero. Like temperature 0 doesn't means actual no temperature, or there is minus temperature also, there is plus temperature also. So Likert scale also can go to -10 to minus +10. So Likert scale also, that 0 doesn't means the absolute zero. Sometimes this Likert scale, there is controversy. It is considered as ordinal, or some statistician is considered as numerical also. But if there is a few number, then it should be treated as ordinal, like 4 or 5 Likert scale. Maybe it can't be treated as a numerical, but if you have got range of -10 to 20, then it can be provided treated as a numerical. And ratio scale is a common one that we use, like height, weight, or age. These are 0 means there is no absolute 0, like there is no value. 0 height, it's not possible, but like if there is a 0 in the height means no height. So the absolute 0 is there. So these types of terminology also we come across, and that also determine like what kind of test we want to use. And this table just summarize that what are the things that can be done in the different type of scale of the data measurement. Like for nominal, we could just do the frequency percentage, or sometimes more, which is more that only can, because these are the number. And for the ordinal, because these are order, that you could also find the median, like which is the medium in that order, that could be done. Otherwise, it's also usually we present in terms of frequency and percentage, ordinal data and nominal data. These are the qualitative or categorical data. And interval, because this is a number, so we could calculate the like mean, standard deviations, and subtractions all could be done. But yeah, multiplication, division can be done in the interval, and ratio scale, everything can be done, and it has got the true zero value, as previously I had said. So thus, with that backdrop about the statistics, because just keep that in mind, like what kind of data, and that determines, I'll come in, especially in the analytical part, like how that will determine what kind of data and what kind of analysis should to be done. So we know that SPSS, this is a full form statistical package for social science, and this is only a tool for the doing the statistical analysis. And for that, you need to have a background, or first thought, you need to think first that, okay, what kind of statistics I like to do, what kind of the hypothesis I like to make, and then only go into the statistics. Sometimes what we experience that we do the analysis, there is a, then we start into interpreting, but rather we should have the first hypothesis and all these things that why we want to do, then go in the SPSS kind of statistics. And few tips, as Ashok sir was also saying regarding like Performa and how it will be useful, like using the Google form and converting to Excel and then bringing back to the SPSS. It will be always easy, and data entry can be done directly into the SPSS also. But always it is good to do in the Excel, because it has got few functions that will help us to clean the data, just visualizing if there is some mistake, or if you want to do certain formula also, you could do in the SPSS itself, and then just bring into the SPSS. And during that, just I like to highlight that because whatever we want to do the statistical analysis, it must be done in the numerical, because it must be into numerical. So whatever you entered into the performance need to be converted into the numerical data. Like gender, you could enter as a male or female, but if you want to do the statistical analysis, especially bivariate, multivariate analysis, then we need to code that. Like gender, you could code 1, and male as 1, female as 2, and then we could extract that from the Excel, and then we could give the value. 1 means what, 2 means what in the SPSS, that we could do that in the variable. I'll just show in the example. So make the not, I'll suggest do not use a string data, use a numerical data, or if there is a categorical, also give some number, 1 or 2, like gender, or if for education, primary, secondary, you could put 1, 2, 3, 4, and then we can just label that into the later on during the variable, during the data management. So SPSS, we are very familiar that there is a 2-view data view and variable view. I'll show that also into that. And simple importing is a file open, and then that data, I'll just demonstrate that also.
Because your voice is not very clear. Maybe you need to speak near to your microphone.
Okay, sorry for that. It's now audible, sir?
It's okay. Yeah.
Okay. I was discussing like how to import that. I have already imported the data, but if you want to import a new, then in the top of this file, then there is an open.
Your next file is not shared. You have to unshare this one and then share the SPSS.
Okay, stop sharing. Sorry. Share the screen. Okay. Is it now?
It's okay now.
It's okay. Like I have already just used a few data analysis that I have done for the few colleagues. If you want to extract the Excel, like as in for the other software, it's the same. Like for opening the Word or opening the Excel, then we could do that. We have to open the data, and only thing that what kind of data we want to use, that like SPSS, if you want to do the SPSS directly, that will be as a .sav that we could upload. Or if you want to import Excel, then we have to import from that. Like we have got this. If you want to that, this is from the pain research. Just upload it, and I have already uploaded that and open. Then just it will extract the file. So that was the that how we can import the data. Can be seen now?
We can see that, yes.
Okay, PowerPoint. Just I have to flip the.
Okay, it's all right. Yeah.
Now, after importing the data, few things that we want to do. One thing that we want to label what we have. That's like in SPSS, whenever we import that, like as I said, gender, we could in Excel sheet. I'll show the Excel sheet. In Excel sheet, usually we label as a 1 or 2, not like male or female, because if there is a male, also could be capital M, small m, then it will consider as a different variable. Capital and M and small m, that use is a different. So it suggests to use a 1 and 2. Always use the sheet 1 for that, and sheet 2 use you could code what 1 means, what 2 means, so that whenever we pull that in our SPSS, Then this is the name of the variable that extracted, and it's a type, like what kind of it's that. For the A's, it's a numerical, and width we could decide like how many with 1 to 12. You can just change that, and decimal also required or not required. And labeling means what to be labeled. Sometimes we use the short form that like PAS 24 hours. What that means? It's a visual analog. I forgot the procedure name. So we could just label that, or we could say gen number of 30 seconds. So we could label on that, and we need to define the value. What 1 means or what 2 means. We could just remove that, and just 1 means label means email, and add that. Similarly, 2 we could do, and this means 1 means male and 2 means female. So whenever we do the analysis, then rather than coming 1 and 2, it will come as male and female. So one thing that we need to do that. And another during the data management, another things that will be very helpful is to then record into the, like A's. I have already done A's categorizations. Just I'll just remove this and I'll redo that, so that we could, that will be very useful, because whenever we collect the data, always try to collect in the numerical, because we could do the subcategory itself in the SPSS. So we don't have to categorize or just less than 40, more than 40, and only during the data collection itself. Otherwise, sometimes numerical data will be very helpful for the analysis. Like if you are collecting BMI, then you don't just don't do the categorization normal or malnourished or obese or category. Rather collect the actual BMI itself or height, weight, and then we could calculate BMI and categorization in the itself in the spaces. I'll show how to do the categorization. To do that, we have to go to the recode into the different variables. It will create the new variables out of the previous one, like recode into the different variable. We are going to categorize A's, and we have to give the name. We'll say A's category, and change is the one we could label also that A's category on that. And then we click the old and new value. Old value means let me check first what are the characteristics after that.
Dipesh, your voice is very fluctuating. I think you need to use microphone very near.
Sorry, just to see the is what kind of range is that. So that we could divide on that. Like A's, we have got minimum 10 and maximum 36. So is the A's group. So we could divide 10 to 15 and multiple of 5. We'll try 10 to 15, 15 to 20, 20 to 25. Okay. And as I said, we could recode into different variable A's. Then we'll use the this name that is A's category, and old and new values. So we'll use range 10 to 14.9, because whenever you do the recoding, just it will include both lower value at the absolute value. If you want to make 10 to 14 or less than 14 and 15 to 20, not including the this upper value, then we could do that. And new value we could just categorize as 1, and if we do similarly, second 15 to 19.9, and then we could go 2 and 22, 23.9. We could give 3. This we could do the same way up to the 26. Just I'll show that this is a demonstration. Then if we click the continue and okay, then we'll create the new variable that's come on our data, like age category. We have got 3. Then we have to again give the value, because if we use the what age means 10 to 14.9, 2 means 15 to 19.9. Similarly, 3 means 22, 24.9. So this way we could do and create the new variable. This is a very important, useful one. If we have a numerical, like if we have a scoring system, then that previously sir was in UCLA scoring system, and if we want to categorize like that scoring system into the different categories, then this will be very much useful one to categorize. As we categorize for A's, we could categorize by any numerical into the different scoring system. Scoring system are like high, mild, moderate, severe. Same way we could do the that. And another that commonly we use is another function that commonly we use is a function. This is for another one. Here I have done the BMI. I'll just remove that and just demonstrate like how we could generate or transform new variable. Like if we want to calculate the BMI, then we could just use the weight in kg, and it's like same like calculator. It's a divide sign is this. Then within we could use bracket also, and height in meters. I have this height in meter, height and multiplied by the same height in meter square. So this is giving me the BMI. I deleted that. Again, I can just generate the BMI. And again, now I can categorize that into, okay, it's a normal, it's a malnourished, or normal or obese, the same, using the same function that we use, like BMI numerical 2, we can just categorize that BMI categorical, change the new value. Means something that's less than 13.5 is considered as malnourished. Then we can give range through lowest, means from the below 18.5 up to 18.5 will consider as 1, and range is like 18.51, more than 18.5 to 24.9 will consider as a normal BMI. So add like that, and this we categorize 25 and above. We'll just categorize as a 3. That's we consider as a overweight or obese. Let's do only 3 categorizations. Then we could create another variable. Sorry, this is not the one. Here we have created another BMI categorizations, and then again we have to define what 1 means. 1 means 2 means normal, and 3 means overweight and obese, 25 plus. Then we just created the 3, and we can just see what we have done in the descriptive statistic. I'll come into later into frequency. BMI category, that's our finding. Yes, we can see that. Okay, total there are 314, missing 6 are missing, and either they don't have weight or height missing value, and out of that normal are 231 and malnourished were that 23, and overweight and obese were 60. So this way, this is a very useful one. These 2 function is very useful, and we don't have to worry, or during the performance we didn't have to do that. If we initially calculate BMI and categorize, actually if we want to do the numerical analysis, see the numerical associations, then it will be very difficult. But we can generate a new variable, and out of the numerical variable and categorize or do the calculations, like we can change into CM into the meter. I had already done, though we have taken in the data collection was done in the height in centimeters. So these things can be done with these two variables. This is a very commonly used variable. And third function that I like to show you is about the select. Like if we want to do the analysis among only the male group of patient or any group of patients, then we could just select the particular cases. Like in the data, there is a select functions, and if we select, and we have to apply the if conditions. Like if we want to include the age category, a gender, gender only equal to male. Male means we have got 1. So if we select only sex is equal to 1, this condition applied, then it will be only selected. That we can see from here. Now this is the data view. All the female were crossed, so it won't be used for the analysis. Now, whatever we do the analysis, like if we do the speed or frequency, then let's do the gender itself. So the data will show only male. Female are not selected. Like we selected if data condition apply for the male, then only do the analysis. Means we could do just define the select a particular group of and do the analysis among that group. So this is also the very useful function that that will be useful during the doing the SPSS analysis. And again, we can just deselect that or select all cases. Then again, we can come back to the as previously you could see that all the will be deselected. So these are the 3 functions during the data transformation that will be very useful. That's commonly useful one during the doing analysis. So thus demonstrating that, now I'll just move into the what we could do as a descriptive. Like in this studies, we could do the descriptive analysis and the analytical one, or association or bivariate or multivariate analysis on that. And descriptive, it's also depend upon the what kind of data you have. Like if you have got the categorical data, like as I saw, nominal, ordinal, then frequency is the one that we could use. And there are options that you could add a table or pie chart or bar chart that you could do for the categorical, as well as for the numerical. So you could do, but sometimes it's not that helpful. Like I have already demonstrated, like if we want to see in this study how many male and how many female, go to the analyze, descriptive and frequency. Just you put the gender here, and actually we don't have any statistics to need to be done for the categorical data. And we click the display, it's a default one. So if we see, then there are total 53 male and 123 female, total 166, and frequency and percentage. So this is a very common one, and it's the basic one we do. And then if we want to do the for the numerical data, we could use this explore one. This give all the idea about, like if you want to see about the age, what is the age range or that. And in the statistics, we could select the descriptive statistics. Then this give the here it will show the certain basic statistics, a range of basic statistics, and we could see the plot as well as the statistics. Okay, I'll use the both at display, and it will show like age, mean age, variance, standard deviation, minimum, maximum range, interquartile range, skewness. All these things are available, and you could do the descriptive analysis with that, as well as they will do the stem and plot for this box plot and stem and leaf analysis for the numerical data. So this way you will have got idea. Okay, mine is range is from minimum 10 to 36, mean age is 19.53, and standard deviation 4.5. So it's little bit not that narrow, but it's a narrow one. And so we could have an idea about like what's the median. All these things will give that. Another way is descriptive, and within the descriptive we could do the descriptive same thing. Here we have an option. What are the things we want to add? We could do the all thing. Just you could choose, like you don't want to look everything, just want to say mean, standard deviation, minimum and maximum. Then just we could you see that like minimum, maximum. So you could on that also you will have all the options, but you could have option to select or deselect on that. So these are the descriptive that we usually do. Descriptive analysis according to the type, like that's why I was showing you what the type of the data. For the numerical, we use the descriptive data or descriptive analysis. For the categorical, we use the frequency and percentage is the most common that we use. And I showed in the table like what are the descriptive analysis can be done. So these are the commonly useful descriptive analysis that we could do. So these are showing the same thing in output view. I have shown you the what to do with the numeric data. Same thing. What are the things that we could select? Okay. So till now I have shown you what are the different type of variable or data, and according to that, what are the different descriptive analysis that can be done. And before that, I shown the what are the different how to treat the data, like categorization the data or compute the new data or select the that three function that I showed that. Now I'll move to the basic bivariate analysis, multivariate probability time doesn't permit us. But before moving to the bivariate analysis, a few terminology: bivariate, univariate, or multivariate. Like if how many variable at a time you are analysis. On the basis of that, we could it will be helpful also during the writing the method also what you have done or what you haven't done. Univariate, bivariate, or multivariate analysis. That is terminology. And this the analysis depend upon the variable type, like I already told you, whether it's a categorical variable, it's numerical variables that determines what kind of analysis that you want to do. And also there is a terminology used as the independent and dependent, or sometimes we use the predictor or outcome. And you should have an idea like which is the independent variable or like the cause of the in your research, like what is predicting or cause is the independent variable, and dependent variable is the one outcome. Like if you had want to measure the pain after the procedure, then visual analytical skill would be the dependent variable, because that's your outcome variable. And the independent could be the procedure, or whether they take the medication, pain medication or not, or at what are the procedure or other things that you have done, age, gender. These will be all the independent variable that will affect in your outcome, or that's a visual analog scale or 10. So that's the things also you should have done. And then according to your what is the independent variable or what is the dependent variable, then you decide what kind of analysis you want. Like if there is a category, independent variable is also category, like gender, male, female, and outcome variable is also the category, like BMI. You want to see the association between the BMI and the gender, then both are categorical, and it's also depend on how many category are that. Then it's determined like what kind of test you want to do. If your independent variable is only two data, two variable like gender, male and female, and also the dependent variables of two obese and non-obese, BMI, then you'll use and another term like I'll use related or unrelated. Like as shown in the one of the studies with the knee surgery, if you are following the same patient for a different point of time, then it's termed as the related one. Like the UCLA finding scoring as the time point 0, and after 1 day, after 2 days, after 3 days, if you are taking, then this is considered as a related one, like different time point, but the same patients. The patient, it's not different one, the same group of patient we are following, then it's the term is used, we use the related one. And if we are using only the one time, like after the procedure, you are measuring the visual analytic skills, and then that's are not that, and like the categorization is not related one, or the independent and dependent variable are not related one. We want to see the gender versus the BMI, then that's it's a not related one. Okay, then that time we use the chi-square test for the categorical versus categorical, and if there are certain point need to be fulfilled for the use the chi-square test, like minimal sample size must be 40, more than 40, then we could use the chi-square test if it is the bivariate, and the expected frequency in the none of the cells should be the less than 5. Otherwise, in the sample size of 20 to 40 and the expected frequency is less than 5, that will be shown in the output variable. Then you have to use the Fisher exact test, and if it is a related, then we have to use the McNamara test. And if there is a more than 2 variable category like PMI, say 3, malnourished, and this, then we could use the simple chi-square test or Pearson chi-square test. Similarly, if we have got this independent and dependent variable, like a categorical independent variable like age, and you want to see the average pain score, average pain score between the male and female, then the score is that's a numerical one. And then if we want to, like height, like if you want difference between the male and female height or weight, then that's the quantitative one. And again, then among the quantitatives, you have to look whether it's a normally distributed or not normally distributed. And that I'll show the assumption. There are different techniques, but the easiest one is to see the mean and standard deviations. That easily can be done by looking the mean and standard deviation, whether it's more than 0.5 or less than 0.5.
Since we are running out of time, can you just go to the demonstration directly?
Okay, just I'll share this slide and just go through, and you'll have an idea about that. And as I was saying, this rule of thumb is this standard deviation and mean should if less than half standard deviation is mean, that is normally distributed. And just to show that in the analyzed way, we could do the chi-square is use the cross tabulations, like among the gender is we use the independent variable in the row, and our dependent variable is age. Here it's age category only. There is one age category here, and then in the statistics we have to click the chi-square that we want to do. There are other also, just chi-square, and then in the cell we have to it's observed and expected, and row percentage, because we want to see the whether gender will an effect on the age category. This is not the good example, but like if we want to see the BMI versus the gender, then we continue, and then this will show the output variable, like this here we are at category N, and our chi-square will be coming to this one, Pearson chi-square, and this assumption is not less than 0.5, so it's not significant, and gender and age categories is not going to be significant anyway. So this is the way we could do the bivariate analysis for the chi-square test. Similarly, if we want to do the t-test, then analyze, then we go the compare mean, and if it is a like if we want to compare the 2 time frame, then we have to use the peer t-test, otherwise we use the independent t-test. Then the test variable, like if we want to see the pain scoring at the 600 hours, or then we'll keep the test variable, and our grouping variable is gender. Then we have to define group 1 is 1 and group 2 is 2. This way, just options, and we can have an scoring like male has got mean of 2.98 scoring, female has 2.51. Standard deviation is very high, so actually we cannot use that this normal distribution one. We have to use the this is not normally distributed, but and then whether it's a significant or not, we could see over here. This to tell significant or not, and it's not significant. And here also this equal variance, assume or not assume, since it is a significance, means our equal variance is not assumed, so we have to see the below 1 data, and still it's not a significant one. That's for the t-test analysis we could do. And if we want to compare the different time point, then we could compare mean and paired sample t-test, and we want to see the scoring after 2 hours versus the 6 hours or 24 hours. What's the pain scoring after that post procedure? Then this we can see that mean scoring at the 2 hours is a 2.31, 24 hour it has increased to 2.84, and our it's also the statistically significant, means it's a less than 0.05, means the pain has increased after this procedure that measure at the 2 hours, then after 24 hour measurement pain has increased because of the procedure. So this data shows that because this is measured in the same patient, then we have to use the paired sample t-test.
Dipesh, now I think you should summarize.
Yeah, that is the one I want to focus. Things in the slide, you can I can share this, and another is the correlation. If it is the 2 is a numerical data, then we'll see the correlation. That's the things only I want to share today with the limited of time, and I'll be happy to answer any questions or queries you have got.
Thank you, Dipesh, for your very elaborative presentation. And we all know that one single lecture is not sufficient to present all about the SPSS itself. But however, you have touched upon the very basic thing, that is coding, decoding, and the basic analysis part in different types of variables. Thank you, Dipesh. Now I would like to request to write any question in the chat box if it is there during discussion. We have now very short time left for the discussion, but I would like to use the opportunity having with us Professor Gyanat Baral sir as a chairperson of Nepal Health Research Council. So I'd like to request him or ask him about the in what are the conditions where we can apply or get the approval from the Institutional Review Committee, IRC, or what are the conditions where we have to get the approval from Nepal Health Research Council?
Thank you very much. First, I'd like to thank the NOA organizer for inviting me in such a very energetic group of cohort of this specialty. I think this is the very appropriately chosen topic, subtopics for this webinar, because in research there are 2 parts. One is technical part, another is ethical part. Both have been covered, and it is covered in both submission of research proposal and submission of manuscript as well. In submission of research proposal, we'll see 2 parts only to evaluate the research proposal. One is why is it done, and next is how is it done. Why is it done means whether that research proposal has appropriately or rightly selected the research gap, identified research gap or not. That determines all objectives and the research questions and all. And how is it done is the methodology. It has been covered very well. So this is the good selection. And for manuscript, whether each topic, each subtopic are coherent each other or not, and whether is it applicable or not. So these are the things. These determine whether it is approved, it will be accepted for the research, or whether it is accepted for the publication. Whether it is ethically sound or not, or technically sound or not. So there are 2 parts. One is technical part and the ethical part. For the ethics committee to accept it or reject it, or to advise to reform it or restructure it. So for research council, it has delegated some authority to the IRCs. For every institution all over the country, they can do it for all researchers, except for clinical trials, for the multicentric studies, and for the things where we have to use the genetic samples, or we have to transfer samples, biological samples outside the country, And if we have to use the animals, those cases, those researches have to come to the Nepal Health Sciences Council for approval. Otherwise, every other things are delegated to decide to the respective IRCs. So that is the condition till now. And we have some difficulties in both IRCs and NHRC as well, because we're working, the work has been overlapped for technical part and ethical part. We're doing everything from one committee, both technical review and the ethical review. So we have to segregate it so that our work will be narrowed down and it will be easier for us. It is applicable to the IRC and NHRC as well. We have to reform it. That is the condition how we get approval. And approval should always be given based on scientific value and the ethical value. That is the thing existent till now.
Thank you, sir. I would like to repeat the conditions where we need to approval from the NHRC. So that is clinical trials or intervention trials, animal studies, and the samples which you are transporting outside the country, and the multicentric or the funded by the external sources. I think that is also the one condition where NHRC approval is required. Now, I would like to draw the attention of Professor Jaisa also that many, the research itself for the clinicians we consider is a kind of a burden. That's a side job from our mainstream job, looking after the patients. So taking approval from the IRC, we also consider as a time consuming and a little bit discouraging to the researchers, especially clinicians. So what is your experience in the Pathan Academy of Health Science, that how encouraging to clinicians to take a IRC approval in terms of time, in terms of revision required, and in terms of other helps that clinicians wants?
Basically, what we see, this is for last almost 10, 12 years now. The basic thing is most of the faculties, they think that they know how to write a proposal, but in fact they don't. So this is a problem. For the one issues which keeps on dragging time and again. This is similar to what we see in the journal itself. So basically, when we see the proposal, when it comes to the IRC, if it's well written, this is the reason why in our form we have very clearly written over there what is the title, what is the introduction, what is the method. If they write all those things clearly, it was very easy. But most of the time, what it is, the busy faculties, they will take the shortcuts. And once it's shortcut, then we can't approve it. So it comes back and forth because of football. We give them back, they write it again it comes back to us. So once you fill the form adequately, then it becomes very easy. But most of the time, because if you are taking a study for 1 year, then why can't we spend 1 week to write a proposal? So this is probably just our mindset that ethical approval is just a formality, which is not basically. Because in ethical approval, what Ganesh mentioned earlier, if a proposal is scientifically not sound, it can't be ethically sound as well. If your method is not correct, how can it be ethically correct?
Yeah.
So even when we have, like say in Pathan, we have this research committee is different. They see the first technical part, then they send it to us. But it's still, even the technical part, when they see it, again, we have to see it because ultimately the responsibility is for the ethical committee. The research committee approval is not valid anywhere.
Mm-hmm.
Ultimately, it's the ethical committee's signature that is valid. So what you mentioned, it's a very difficult time. It's very difficult. Sometimes we get all the burden that ethical committee drags upon all these things. So this is the same thing like what is the earlier proposal? It's well-written proposals. We approve them within a week, even a day sometimes. And sometimes it takes even 6 months. We have examples of we up to 6 months. So and then says, okay, oh, my study was planned and all this. This is get familiar with this, be sincere. So at the institute, like it's different than research council. Research council will not teach you how to write proposal, but in the university, we do the same thing. We educate them, we capacity build them. So this is more difficult than research council probably for us at the institute level. Same thing probably you in the KU as well. So it becomes very difficult. So sometimes what our experience is, the residents write better proposal than faculties because they have to pass out. Faculties, they don't have to pass out. So so this is the experience probably what we have at Pata.
Thank you.
I'll just add to this, what he mentioned earlier. Lots of our faculties, they think that this is a multicentric study. For example, one center is Patan, one center is KU, one center is East, one center is BNB. And then when they get approval from the research council, then they don't need to take approval from the local side, which is completely useless because we won't allow them. Even if the research council approves them, site has to. So what this is again chicken and egg. Who does the first?
Yeah.
So basically, we have understanding in research council as well that local site has to approve it, then goes to the research council. Otherwise, becomes again. So this is again chicken and egg. So it keeps on dragging. Yeah.
You are perfectly right that who should be responsible, either IRC or NHRC. I think we will make another webinar to discuss about in details about that.
Exactly.
Baral sir, you want to add something?
Yes. I don't have to speak more on the ethical part because NHRC is also going to revise the guideline for it, and it would be helpful for us later on. I like to inform all the participants. We are 95 now. We are 80 now. Before the number is reduced, I'll inform you all that all busy clinicians are doing their job, and whatever they think the problem is there in the clinical practice, that is not understood by other people. Only busy clinicians will understand it. So we have to make their capacity to do research on their own subject and one problem. So that is the concern, because we are always making data and we are not analyzing it. We are not making it as a research product. That's why I'm planning to start education for those busy clinicians for a fellowship program for 1 year from NHRC under the umbrella of one academia. So it would be easy for them to understand what is the value of the research and how to generate their own research questions from their clinical practice. And it would be for the in hybrid mode, so that they don't have to leave the clinical practice, but they can enjoy, they can join it, and they can qualify themselves, so that all clinicians will be involved in their own research and they will not let their data to be used by others who do not understand the value of that data. That I would like to inform you on.
You have hit the nail. That is why these all webinars are targeted for the busy clinicians. Despite their practice, they should be continually focused in the research also. And we will be waiting for those seminars or the webinars. There's one question that if you do not finish or do not start your project on time after approval from the IRC, and you have to do you want to do next time, then you have to inform your IRC that why you did not complete your study on time and reapply or re-inform and take a re-approval if you want to do the same study in another time period. Now, I would like to
Deepak, just to add to that, any amendment has to be informed. You need to inform to the IRC. May not be the re-proposal, but at least inform them and amend it. So this is an amendment, not the re-proposal, basically.
Yes. Now, I would like to bring the question in the chat box that we missed. You mentioned about the pilot study, Dr. Ashok. So our participants wants to know a little bit more about the pilot study for the sample size calculation.
Okay, so generally it is done on a limited number of patients, generally around 10 to 15. And you conduct the experiment or your surgery or your whatever research you're doing on those patients and get the data regarding the mean, median, and other statistical points for your primary outcome. And based on that, you calculate your sample size.
Yeah.
So it's not, sorry.
Please carry on.
So it's not a very difficult thing. It's like you go on, start your study without a sample size calculation. And after set of 10, 15 patients, you analyze the data and take out the statistical requirement for sample size calculation from that pilot study.
Yeah.
So that's a simple way of explaining it.
Yeah, thank you, Dr. Sam. Pilot study is a kind of a miniature version of your original study to get some ideas and generate some data if it is not available in the literature. It depends upon where and what study you are doing. Sometimes it can be a very expensive one also. But instead of wasting your time and resource in the original study, which is not feasible and not applicable, that you can get the information with the pilot study also. Now there is another question. I think this is questioned by Amit himself, that do we need to calculate the sample size in retrospective study also? I think this is useful for all the participants. So I would like to request Deepesh to answer this question. Do we need to calculate the sample size in retrospective studies also?
As previously said, the sample size is to have an idea like how much minimum sample that we need to collect, and so that we could have enough power to show that our objective or whatever association or whatever the prevalence that we want to show that. So whether it's a retrospective or it's a prospective study, the sample size will give an idea like what is the minimum number. Actually, it's a minimum number. It's not necessarily like 60 means you could do only 60, you could do 70, 80 as well, because we have to trade off between our resources as well as available data. So for retrospective prospective, we need to just have an idea like what's the minimum number that we should collect, and additional 10%, 20% extra on that would be usually that we do the practice at minimum, and 10% for the attrition and all on availability of other data. So what's our main objective in the retrospective? Also primary objective, and we should always target the primary objective one, and that's why the Salami publication questionably also that like always we did the calculation, sample size calculation on the basis of primary. And if we don't have enough data, and if we start breakdown or study and try to publish, then there might not be enough data. Sometimes a large study it is possible, but in the like small study in our one institute study, it might not be possible. So answer is yes, we need to do the sample size calculation.
Irrespective of your types of research, whether retrospective or prospective sample size calculation, if it is required by your study, then it is necessary. So as Deepesh said that it depends upon what is your power of study. If your power of study is very large, then your sample size will be big. And if it is less, then your sample size will be also different. So now I would like to bring Dr. Amit's experience that Professor Baral has mentioned that clinical trial registry has been now started NHRC also, though it is in a very infantile phase. So what is your experience? Are you doing the clinical trial registry in NHRC or any other forum before you start your studies?
Thank you, Deepak. When NHRC has not opened the trial registry forum, we have used other portals. You can register. It is not necessary to register only in JNHRC. If you are doing research in Nepal, it is not necessary. You can register in any of the trial registry and get it registered, get your registration number, and start your trial. Number one. Number two is what I would like to maybe Baral sir will also highlight on that what we think it is a trial may not be a trial. So identifying what is a comparative study and what is a trial, the differentiating between comparative study and the trial is very, very important. Most of the time what we say is two groups randomly selected and then, looks like a trial, but actually this may not be a trial. This could just be a comparative study. So there are certain criteria to be labeled as a clinical trial. Unfortunately, NHRC has not given that criteria. If you go to their data and what are the available, they say that whatever you do, it can be trial. Even there is a gray zone between the comparative study and the trial, and the NHRC is not able to explain in their website what exactly the trial means and what exactly the comparative study means. So, but I absolutely agree. All the trials, Until unless you have registered trial, it is not going to be published. That is what I want to say.
Yeah.
They will not ask where the trial has been registered,
That's
but the trial has to be registered.
Yeah, that's true. That is important for the researchers also, so that they do not have a duplication. If something is you are doing and another researchers know that that particular thing is being done somewhere else after the clinical trial registry, then they will not repeat and use their resources, valuable resources in duplicate research. I would like to also ask Dr. Ashok about the experience in registering clinical trials in India, because Indian clinical trial registry is the WHO approved trial registry. So would you like to highlight something upon clinical trial registry in India?
I think it is a very well established CTRI. So we register, in fact, all our theses into CTRI. Also, all the medical students, not only orthopedics, we have a physiotherapy college in our institute also, we register everything into CTRI. So not only the clinical trials, but including the thesis, everything is registered. And once we register there, we get certain queries from their side, basically on the study design. Once we answer those, it is approved, it goes through. Most of the journals now are also asking for CTRI registration and the numbers. So we are doing it in that way for publication also. It's helping in publications too.
Yeah, in some places, this is not by choice. This is by default. You have to do it.
Yes.
Otherwise, your articles will not be published. But we'll be, I think, Baral sir can highlight that at what stage we are now in the clinical trial registry before we start any our project or any research. Baral sir, would you like to highlight?
As the clinical trial registry is the must for the clinical trial we do in our country. NHRC is planning for it. And till now, whatever agency is there, like Dr. Amit said, we can get registered from there. It's not mandated that we have to go for the NHRC only. It is still in the infantile phase. We'll do it later. Then we'll make it mandatory that there should be clinical trial. But there is one problem with us. The researchers are not well informed about or are not aware of the type of research that is clinical trial or comparative study. That is the problem. That is the high sounding methodology design is there, but whenever I go to the text, that is not clinical trial. That is just comparative study, observational analytical study only. So if many of the studies that have been submitted in NHRC, or that has been submitted in some academia for the dissertation, those were not the clinical trial. They are just comparative study only. And we have to make it later on. Till now, we are not registering it. We are in the process of making some trial registry forum in NHRC, not for JNHRC, it is for the NHRC. Okay, and this is we have two roles of the NHRC. One is to regulate the research, and is to do the research for the policy and for the advice to the government. So this is the part of the researchers to know what is clinical research and what is the type of design they are applying and what is the research type that we are going to do it. That is the education part. So we're trying to make it available for all types of resources from the NHRC, including education and training from there.
Yeah. What we have to understand for the benefit of all the participants that NHRC or IRC or clinical trial registry, they are not the discouraging factors. They are in fact encouraging factors. So they are all make sure that whatever you are doing is doing in the right way, so that we do not have a problem later on. So let us take them as a facilitator, not the burden. So that is, I think, the message that the Baral sir want to convey. So I think we are running out of time also. Before we conclude, I would like to again ask Dr. Ashok and then Professor Amit that you mentioned that in material and method, there are certain fixed guidelines. Like for the randomized controlled trials, you have a consort, and observational trials, you have a stroke. these are, I think, requirement for the journals also. Unless you report in their format, they will not accept your article or your manuscript also. Would you like to elaborate a little bit more that how exactly or how strictly we have to follow the guidelines given by the consort or the stroke?
For consort and for randomized trials, very, very strictly. In fact, you have to mention in the article itself on various parameters and give the flow diagram for consort for randomized trial. Absolutely essential for any good randomized trial to be accepted in any good in current scenario. So it has to be there. Consort is a very recent thing. It's introduced in 2010 and has been propagated in 4-5 years. So most of the journals started recognizing it in last 5-6 years and have made it compulsory for you to follow this. They are very good guidelines and good standard guidelines. They help the journal to decide whether it is a good randomized trial or poorly randomized trial, and they actually categorize according to level of evidence based on that. So it is absolutely essential if you're doing a randomized trial. Stroke guidelines are much looser. I mean, they're kind of loose and since they are related to observational studies, you can modify and utilize that. I mean, there is no hard and fast, but they are good guidelines. Like it is, like the name implies, there's a guideline. So they guide you to get the best paper out of your study. So utilize them.
I would like to same questions to transfer same question to Professor Amit also. How often you are following these guidelines, stroke or the consort, and have you experienced any that your article is manuscript is not considered because you are not following the guidelines?
Yeah, I think following a guideline will help you rather discouraging you. If you follow the guideline is based on the process, and if everybody follows the same guideline as Dr. Ashok is saying, and it will help us in comparing certain papers as well, between each papers to identify either it is written in the format or within the guideline, or your paper is written outside the guideline. It will be very easy to decide either the journal is going to accept. If you want your journal to be paper to be accepted in a journal who says that write according to the guideline, you better write according to the guideline. So if your journal says that use STOVE guideline or whatever guideline, and your paper is not according to the guideline, from the day one, it is going to be rejected, So it depends upon journal to journal. Some journals strictly follow the guideline. Some journals do not follow strictly the guideline. So it's important to read the instruction to authors. And if that journal says that it has to be according to the guideline, better you prepare your research and prepare your article according to the guideline.
Thank you, Amit. These guidelines are really very useful for the researchers because it will make sure that everything has been taken care of completely, and less likely you will miss any important things or any important information. So it is better to follow the guidelines. For the sake of the participants, the randomized control trials, if you are doing, you have to follow the consort guidelines, CONSORT. And if you are doing the observational study, then there is a guideline called STROBE, stroke. Now, before wrapping up our discussion, I would like to again request all our panelists to give a conclusion remarks if something has been missed. So let's start with Baral sir, then Jaisa sir, Dr. Ashok, Dr. Dipesh, and then Dr. Amit. Baral sir.
Thank you very much. In summarizing this webinar from my side, I've already mentioned that the topics selected were appropriate, but only the time limit is there. Okay, and we should have made this analytical part a separate webinar so that it will be comprehensive and it will be helpful for the participants. Otherwise, all topics are okay. These are the major parts, and it was very well done, well appropriately made. And there should be some hands-on experience on proforma, filling up of the proforma and the analytical part in SPSS. Otherwise, it's okay. Thank you very much.
Sir.
Yeah, I'll just take my part first. That ethical committees, they are there to help you, basically. Follow the guidelines, be sincere to fill the forms all completely, then it becomes much easier. The problem what we have, this webinar, we are continuing this the third time, probably we'll do it again continuously. Lots of our clinician, I think it's always better to have a researcher physician, not only physician. We are good doctors. But what is wrong to being a scientific doctor? This part of what we have to get internalized first, and things becomes very easy. We're talking about evidence in medicine, but we do not want to generate the evidence.
Yeah.
So this is probably what the problem we have. So it will be very good. Slowly we are picking up and it will be better. Thank you.
Dr. Oxford, please.
Yeah, so in fact, similar situation we are still facing in India also. A lot of clinicians are reluctant to publish and are scared to take that first step into the publication area. I think they have nothing to be scared of. We are all doing research. Research is nothing but pursuit of knowledge for providing better patient care. We are all doing research when we are treating patients, when we are reading journals, when you are doing surgeries. What we have to do is just formalize it, make it in a formal pattern, set your data collection in a very simple way. Don't collect all data. Create selective data collection and start writing. Take help. Taking help is also very, very important. A lot of people are reluctant of taking help of. I see such a dedicated group of researchers from Nepal. I think everybody should take help of you guys. Start writing, start doing projects, start with case reports. Start. Take the first step. Once you start doing that, the rest of the things, Dr. Deepak is here, Dr. Jay is here, everybody is here to teach them the advanced stuff and everything else. So it's nothing to be scared of. You have to just start with the step one and go with it. It is like adding to the subject of orthopedics. There is no other way to add. So yeah, make it a call.
Thank you, Dr. Suk. Amit, now it's over to you.
I think I'll copy and paste what Dr. Ashok Sham said. Until unless you have a first step towards doing a research and writing a paper, there will be no ending of it. So you should start. There are people helping you out. There are colleagues around. There are seniors and juniors around to help you out. And I'm sure if you ask any help with Ashok Sham sir as well, he'll always be ready to help us on writing. So we must make a first step. It's always difficult to start. But once you start, it becomes so easy to do it again and again. You'll enjoy. Once you finish one research, then you'll enjoy doing it and you'll continue doing it. So just start. That is what I want to say.
Yeah, completion of the one research is a kind of a cigarette. So you want to light on another one once you finish your previous one.
Very addictive.
Yeah. But not only in orthopedics, in fact, in all other medical field, we have now a very good group of researchers in the medical side also, and very good articles are being published in the very high impact journals or even the books. So very big trials are going on. Dr. Baral can give a list of, I think, very, very big trials and the research in medical fields are going on. But as Dr. Ashok has very rightly said, beginning the starting is difficult. Once you start, then it's a kind of a sailing in a very, smoothly in the ocean. And that is the introduction. As I said, that the beginning is difficult. So let's break that difficulty and carry on our, the research activity, not only the clinical part. I think this is the overall for today's presentation. Now I would like to request Amit to carry on the other formalities.
There are no formalities. Thank you, everyone. On behalf of Nepal Orthopedic Association, I'd like to thank especially Dr. Ashok Sham sir. He could manage all these out of his very busy schedule. And on behalf of all Nepali orthopods, I would like to especially thank again Dr. Ashok Sham sir for providing a platform like Ortho TV and orthopedic research group, which is helping us a lot. I request all our colleagues to go to OrthoTV, try to find out a lot of, webinars on research and other webinars as well, which will be very, very beneficial. So I think Ashok Shyam sir is doing a, tremendous, fantastic job, which is beyond the borders of India. It has gone global. And, Ashok sir must be commended. And on behalf of Nepal Orthopedic Association, I would like to congratulate you and, thank you very much for that. Other faculties, sir, Baral sir, they are, always available to us for how and, to what extent we want to use them. They are always available to us. Thank you very much, Baral sir and Jay sir. I think if there are, our secretary is here, he can give some vote of thanks. Otherwise, we are done for the day. Vinod Sersan is not there. So I think my words will be...
Vinod is there.
Vinod is there?
Yeah.
Okay, Vinod, you can give some vote of thanks if you are there.
Vinod? I think his only name is there, he's not there.
Okay. So I on behalf
can I just say a few words? Can I just say a few words and thank you?
Yes.
Last words. Sorry for the last this thing. So I'll just tell you a small incident that happened in Nepal a couple of years back. When Professor Itoy, I think most of us know, he came to Nepal and in one of our conferences, he said Nepal has gone a lot in research. So I asked him why. And he said, most of the papers that were presented said it was a randomized controlled trial. And he said, you fellows are doing randomized controlled trials. And I was in a position to say to him that it is not a randomized controlled trial. The people are doing, like we've been discussing now. Now we realize, people must have realized what it was when they were saying randomized controlled trials. So I think these seminars, these webinars must have shown light on what a randomized controlled trial is and what a clinical trial is. I think, thank you very much, all of the faculty, and in trying to make clear to all our participants what really research is and how we should proceed. I think for the last couple of years, we have gone a bit forward, but we still have a long way to go. And I think these type of webinars will really help us in setting a standard where at least we can say that now actually we are doing